to the meeting today, but this is Joe's first meeting as Chief Exec. So congratulations, Joe. Welcome to the meeting in your new status.
Thank you.
I know that you have the full backing of all of the board to make a huge success of being Chief Exec. So good luck. Now, before I move on to anything else, I mean, normally the report of the new Chief Exec taking up would be the most important executive announcement of a board meeting, but I hope Joe will forgive me and say on this occasion it isn't, because this is Monica's last board meeting before her retirement, and I mean, I have to say, Monica, you and I knew each other back in the days when you were first appointed 23 years ago as, was it Director of HR or Personnel in those days, Monica?
I think it was Personnel in those days, Steve.
I think
Training.
I think it was. So we're of the same tribe, aren't we, you and I, Monica? So, I mean, I have to say 23 years is a phenomenal contribution to make to an organisation. And it's been an outstanding, not just a long-serving contribution. You will be hugely missed by senior leaders and senior clinicians and board members for your wise counsel, and you've been able to do that in, you know, when there've been good times, but when there've been tough times too. So it's a richly deserved retirement, I have to say, Monica, and I'm sure, I know everyone over the next few weeks will be wishing you well, but just know that you leave with the very grateful thanks of the board.
Thank you, Steve. I really appreciate that, and it's been a real privilege to work with so many committed, talented and dedicated people, and a real pleasure to be leaving in a way at this time when the trust, both in terms of the financial performance and also looking forward to all the things that will come. So thank you all.
Thanks, Monica. Leave them wanting more. That's always the rule, isn't it? I think that's it. So to keep going through the agenda, to save Monica's blushes, if nothing else, we've got no declarations of interest. Minutes of the meeting of the 4th of August. Are people content that they are an accurate record of proceedings? I will take silence as agreement. Going, gone. The one matter arising has been completed, so I think that takes us straight to agenda item 5, which is board committee chairs feedback. Audit. Nikki, can we start there, because it's the first letter of the alphabet?
Thank you, Steve. So the first thing on the audit committee's agenda was the data quality framework, which was an advisory piece of work that we asked TR and auditors to do for us, looking at how we can assess the quality of the data on which we rely to make decisions. So they produced a useful framework for us to help us understand what risks and controls there are in relation to the data that's compiled for us. Sorry, that's my dog joining in. So the challenge for us now is how we use that framework in identifying areas for internal audit work, but also for informing us and the decision makers in the organisation about the quality of data on which we're relying. So that's something for us to take forwards. We then looked at the BAF, which I think as a committee we are significantly happier with the new format. And we would support the recommendations to the board for the changes 3 of the BAF risk levels, So BAF2s, there's a recommendation about increase relating to the backlog, and risk 7 and 8, there's a reduction in residual risk as a result of the increased capital that we've got at the moment, but I'm sure Lynette will talk more on that later. And then we looked at the risk register, and I think as a committee we're agreed that the challenge now is to really make sure that that register is of a similar quality to the BAF. I think it's a good document as it stands, but there's definitely scope just to make sure it's really up to date and as useful as possible. A clinical audit, there was just one area that was raised, which was where the trust is an early outlier in the National Early Inflammatory Arthritis Audit, but that's already been looked at by the Quality and Safety Committee, and we just formally agreed that that would sit with them in terms of responsibility and tracking up. But there is a plan in progress with the clinical teams to look at why we're an outlier and to make sure that's moved forward. In terms of internal audit, there was a report from internal audit on our critical financial assurances, and received substantial assurance on that. And the one I really wanted to talk about actually was that internal audit looked at our revised governance arrangements during COVID, and found that there was reasonable assurance. And I just wanted to commend the teams because, you know, they were obviously working under huge pressure during that period, but internal audit found that the revisions that were made to practices were in line with that which was reported to the board. Decision logs were being maintained, and I think that's a real credit to the teams. The only area of concern was the internal audit report on IT continuity, which found limited assurance, and we have asked for a sort of more detailed report from the IT side of the business to come to the audit committee to look at that in more detail. But internal audit did reflect that the agile ICT response to COVID demonstrated considerable resilience in that area. It's just getting a little bit more comfort around the overall robustness. The other thing I wanted to flag actually in terms of internal audit was that they maintain a tracker of all internal audit recommendations coming out of internal audits, and there's nothing outstanding on that at all at the moment. Again, testament to the team's focus on making sure we're really responding to internal audit recommendations. Counter fraud, it's just ongoing proactive work, including a lot of liaison, I believe, with the finance teams at the moment to do with COVID related risks. Information governance, their report, I think the main thing to flag was that there had been a data breach that raised the issue of other organisations using ESHT software and having access to ESHT data. But in response, the Trust is undertaking a review of organisations who've got that access. And then finally, we looked at tenders and waivers. There's been significant progress in reducing the number and value of waivers that the Trust is seeing, which is testament to the finance team's focus in that area and new leadership of that team. However, activity around building for the future has raised the profile of procurement via framework, and in response, the Trust is now reviewing and amending its processes to increase formal scrutiny to ensure best value for money. Great,
thanks very much. Thanks very much, Nikki. On F&I, as colleagues will know, we break F&I into finance and into strategy. On finance, it's probably been the strangest year for finance that I've ever known in the NHS. So we spent our time looking at trying to understand allocations, how we managed through the first 6 months of funding, and how we prepare and are ready for the remainder of the year, which will have a different set of financial rules applied to us, how we respond to that in practical terms, and also preparation for next year during times of considerable financial uncertainty. We also spent some time looking at capital expenditure items and process around capital. On strategy, a number of things have been done. We're working on revisiting our priorities for the immediate period and signed those off, and doing some preparatory work for a refresh of our strategy, and of course spending time looking at the Building for the Future programme and making sure those two things are connected, and agreeing a process over the course of the next few months that would allow us to put all of that together, and much more work to be done in the coming weeks around that. So that's probably all I plan to say on finance and strategy, and obviously we'll hear certainly more about finances later in the agenda. People and OD, Miranda.
Thanks, Chair. I'm going to have to go onto some notes on a different part of my electronic device, so you may lose sight of me.
Okay.
So we met on the 3rd of September, and the main things we discussed were the people plan, the NHS people plan 2020 to 2022, which focuses on 4 key themes: looking after our people, including keeping staff safe, healthy and well, physically and psychologically; belonging in the NHS, which is about organisational culture; new ways of working and delivering care, which is about making effective use of the full range of skills and experience to deliver the best possible care; growing for the future, which is about expanding and developing the workforce. We went through the plan. We looked at the things that we are already doing at ESHT, and I think the committee felt that we are already undertaking a lot of the elements which are within the plan, but it would be useful to be more explicit about the link between what we are already doing and what is in the plan. There are some milestones in the plan which we'll be reviewing on a quarterly basis. And in fact, the action plan for this is almost complete, and we'll be looking at it at our meeting next month. We had a discussion about how we could bring the plan a bit more to life and embed it in our culture, and have a wider conversation within the trust on this. And so I think this has to be done through line managers, and also it needs to be embedded in how we lead our staff and our leadership programs. We talked about equalities and the res and also the disability side of things, and we're coming on to that later on today, so I won't spend any time on that. We touched on the staff survey, which was launched within the Trust on the 21st of September. We reviewed the board assurance framework, the specific risks relating to POD. We looked at the sustainable workforce, which is BAF4. We're going to have that as an agenda item, a workforce supply update this month. We talked about protecting our staff. The last time the board reviewed the board assurance framework, the wording for this particular risk was a little bit shady. I note in the report that is before you today, this risk has been updated with all the initiatives that are being undertaken, and in particular adding well-being and violence and aggression to the risk, which is something supported by the committee. We took the employee relations report, which is the regular report we take on staff complaints, conduct issues, employment tribunal claims, etc., and we went through that. And there was a decrease in that reporting period over the number of formal cases raised compared with the previous comparable period. There has been a lot of work on trying to promote people using more informal methods, I think, and trying not to let it get to the state of a formal case, and so perhaps that is bearing fruit in this. We had the workforce report, which is the normal dashboard that we have regularly, well, every time we meet, the vital statistics of the organisation. We noted in sickness absence, there's been a large increase in people being absent by virtue of anxiety and so on. And so we had a discussion about whether people's psychological needs were being met. There is a lot of support that's being offered and a continued focus on this. So we did feel assured about that. We discussed the Guardian of Safe Working quarterly report. An issue that came up from that was lack of engagement with the team, and I want to explore that a little bit more outside the meeting, find out a bit more about it, and we may need to have a deep dive on that. And those were the main things we discussed.
Right, thanks very much, Miranda. Jackie? quality and safety?
Thanks, Steve. The main thing with quality and safety is we agreed the quality priorities for the quality account for this coming year, which is a good thing. We've done a lot of work on that and we're being quite ambitious. So we are going for 3 things, which is we're in line with the structures, which is perfecting discharge, embedding safety and infection control excellence. So that will guide the strategies and quality going forward. We also heard that the lone worker business case is now in the final stages, going to the business group, and we are keen to completed so that we eliminate any potential risks. We've agreed to invite the chiefs of divisions to the strategic element of the future meetings. We looked at the BAF, and I know we're coming on to it, but we were concerned still of the size of the ophthalmology waiting list, and also how we conduct a formalised review at the end of each quarter, just to understand that process. We also thought the diabetic screening on the risk register rather than the BAF, the time to clear the backlog is too long. In terms of governance, there was nothing outstanding other than we had a discussion about changing our approach to falls and changing our mindset to be that we will assume you will fall unless we do something, rather than assess your ability to fall as a patient. We now have a BAF for infection prevention and control, which becomes a standing item for the committee, which we are very pleased to see. And so far, we are on track and delivering to our goals. In terms of the winter plan and recovery, we are concerned with the bed gap and feel that this is going to be a tough winter to deliver on our constitutional standards and reduce the waiting list and comply with COVID when we have got a bed gap. We are concerned at the number of people waiting to come in and the length of those waits, which I'm sure we'll come on to. And that was it.
Great, thanks very much. Jackie, so much talk of the board assurance framework in all of that feedback, so that leads neatly on to you, Lynette. I don't think I've ever talked about the BAF so much in my entire life.
I know. Well, hopefully the new model is working, and so it has. As colleagues have said, it has been reviewed by, I think, probably all of our board subcommittees. And at some of those meetings, we also go through the risk register as well. So we review both documents. I think probably the most useful page is the summary page, page 2, which is a high-level overview of each of the risks, the objectives impacted and the movement. And also we've added the risk appetite, so that's a new addition since the last version that came to the board. We're seeking board approval for BAF2 to increase from 12 to 16. And the reasons are, as Jack has just cited, really around our increased backlog and waiting time. So there's some focus on that, but the risk has increased. And also for BAF 7 and 8 for the risk to be reduced because of the availability of capital. We've got more capital than we have had in a long time. Yeah. So I need board approvals for those 3 movements. And also, just as Amanda has already said, we've rewritten BAF 5. So instead of it being, it was very much focused on COVID risk assessments before, and now it is written to reflect risk assessments around violence and aggression and lone working, and reflects the actions that we're have in place for those. So I'm happy to take any specific questions.
Okay, so first things first, Miranda.
I just wanted to say I'm happy with the changes, but the question I raised last time, which is, does this really feel like an organisation that has so much red in it, has actually been effectively answered by the changes that you're proposing, because I think you are more adequately reflecting the mitigations we've got in place. So I'm happy with that, and for me it feels more like it really is in the organisation.
Yeah, thanks, Miranda. Jackie?
Thanks. I agree with the recommendations as Lynette has stated. I'm just a bit would like an update really on BAF2, on the actions required. That we're showing orange on returning and relocating suspended services, including EMU, oncology, ophthalmology and cardiology. As we're showing orange, is that because we're behind, or have we got a resolution for those services, and include paediatrics in that?
We've got a conversation about recovery and restoration in part 2.
Okay, I'm happy to take it then. It's just so to note.
Yeah. Jo, did you want to just come in at that point?
Yeah, just very briefly. So much of that is resolved now. I think what it might be helpful at the next board meeting is to bring a summary of what is not. So I think there's two separate things. So one is activity getting back to normal, and the other is the services, the location of those services being back to where they originally were. I think it would be helpful to bring that to full board in 2 months' time. I can say that the majority of services are back as they were, and some of those probably just can be updated over the next couple of months. I think Imran will pick up probably the percentage of activity compared to last year in his element, but most of that is restored now in some way. But I won't go into all the detail now, but we can pick up a little bit later in more detail when we've got a bit more time.
Great, thanks Jackie, thanks Jo. So then specifically then to Lynette's requests to approve the change in the risk ratings, that's agreed unless anybody thinks otherwise. I think we have the continuing challenge that Nikki reflected of making sure that the document stays live without it becoming a kind of bureaucratic nightmare of kind of recalibrating the document, you know, every month or something. So otherwise, everyone content? Great, thank you, Lynette. Now we come to agenda item 7, a new style of chief exec report. Jo?
Yes, so probably what I'm going to do is just draw out a few key elements, recognising that the execs will pick up their areas within their IPR. So just to draw out a few things. So firstly, I just wanted to say thank you for your kind words earlier. And I am immensely proud to start as chief exec, as all you know, and many people do, if you've seen the little video. It is where I started my career, and it's great to sort of be chief exec of my local trust. So I just wanted to say that. And I know with colleagues that we aim to take the organisation. It's the next step in the journey, and it's an opportunity to build on all the hard work that everyone's done so far. And thank you for Adrian for leading us all through that. So just to draw out a few key things really. We are focusing probably on 2 key areas, but I'll draw out a bit more than that. So one is that from an elective perspective, we are trying to return back to pre-COVID activity levels, and Imran will take you through that in more detail. It's not quite normal, it's a new normal, and we are obviously trying to work within the infection control and social distancing. So it looks and feels a bit different, but we're trying to make sure that patients have got access to services that they did before. There is the phase 3 letter that others will may refer to. That is the submission that we have just made, which is around our finances and our activity and our essentially how we're doing about returning back to normal. That has taken quite a lot of time up, but it has helped drive us forwards, and we're doing quite well in terms of returning back to normal, but a couple of areas that still to push on. The other, of course, is winter, and that's been raised already, and I know there's a paper again, so I won't go into detail on that. But the team have put significant efforts into working both internally within the organisation, but importantly with our partners across the CCGs and the local authority and other provider organisations to make sure we're as robust as we can
for winter. And within the context of that is, should we get a second surge, what would that look like as well? So those two areas are primarily taking up all of our time. A few just linking into that really, and David may well cover, just to say that current COVID levels are still quite low in East Sussex. They are being reviewed with Public Health England daily and certainly weekly, and we're very much part of that conversation. We've got currently, there's one patient in ITU at Eastbourne sadly, and 4 patients at Conquest, but it's varying between sort of 2 and 5 patients for a little while, but others may go into more detail. Exciting news, so 111 first, which I think we've talked about before. So this is where the 111 service has now launched its clinical assessment service. So patients that are to be directed to ED from 111 will go through a clinical validation and see if those challenges or support that patients need can be given over the phone. If not, the aim from the 15th of October is that we will book patients directly into our EDs, into our urgent treatment centre, and into some of our gateway areas, so acute medicine, for example, and acute surgery. We will be the first to go in East Sussex. There are a few pilots. There's been one at Medway and one in Portsmouth. We are working with colleagues in other areas, but Medway only went live just over a week ago, so little too early to share. But the idea is that we can support patients better by giving them appointment times. It's a better experience, and we can hopefully even out some of the demand if it can't be managed over the phone before it comes to us. The front entrance at Conquest, for those of you that have been in and around recently, is now open in terms of, well, the reception area is open. I went in to see them yesterday. They're already very pleased. It looks great for patients. And it's great for our staff who have got a new area, and it's a little warmer than it was before as you walked through. The actual entrance itself will be open by the end of the month. There's just a little bit of work going on outside still. And then lastly, building for our future. We would have seen that the Prime Minister announced and confirmed funding for the HIP programmes, and we were within that list. Just to say, we are still working through our business case. At this stage, we're not expecting that there's any change to that. We still need to work that up. As I've always said, this is a clinical change programme, and the building will be designed to meet our clinical services. So we're currently working with the healthcare planners and our clinical teams to design what services need to look like. They're just starting to meet with the design teams. And then we will be able to share what those designs look like. We've also just launched the public engagement yesterday, and if you go onto our website, and I know Liz is here with us today, Liz is very much a part of that as are other stakeholders. So we're keen to hear people's views, and we're keen to hear our staff views again, so we can design a building that meets the needs of our patients, our public, and importantly our staff as well. The 6 million enabling works, we've now starting to spend the money, so the contractors are on board. They've started the site surveys, and it's great news because it's real and will come alive. So that's all I was going to say. Thank you.
Great, thanks, Jo. Miranda first, then Jackie.
Thanks. I wondered, Jo, whether there'd been any initial public reaction to the plans, because it was quite an exciting and uplifting presentation in the press release. So I wondered about that. Secondly, will there be written chief executive reports in future?
So just to take the first point, so in terms of the plans, it was launched yesterday, and we did put out a press release yesterday. So to my knowledge, we haven't had those, well, it haven't come back to me at the moment. The plans are still being drawn up, obviously, because we're trying to work quite quickly. So once we've got those plans, we will be able to share them in more detail. We haven't actually done the planning, the design work yet. So there'll be more next time we meet and over the next sort of few weeks, really. In terms of written chief exec's reports, so Steve and I have discussed that, and we wanted to make sure that we just drew out a few key things. So I wasn't planning on that, but if people feel differently, I'm happy to do so.
Well, maybe we can see how it goes.
Yep.
Yep. Jackie.
Thanks, Joe. Just bearing in mind the timetable and the need to get something submitted this side of Christmas, I just want to make sure that we are looking to provide the hospital for how things are going to be rather than how services are now. So, and how are we getting that advice on designing for the future?
So I think there's a few things in there. One is that we are asking our clinicians to help design those services, and we've been encouraging all the way through that they design the services that they need to be innovative in the way they work. The healthcare planners, they are the experts, and they will be drawing from the various HIT programs around the country and linking in again so we can sort of test and push a little bit further and design for the future, because you're right, we don't want to just pick up and drop what we do now into the same services, into the same just carry on as we are. And then the design team, I think, will help push that a little bit as well. Tracy and Chris have also talking to NHS England, who are also supporting obviously other HIT programs. So I think there'll be a reasonable amount of challenge. There's also from our governance is that we will need to make sure that the plans are supported by the CCGs and other organisations across Sussex. So I think we will share those as we go along. So I think there's the opportunity for challenge and support and advice as we go through that.
Okay, thank you.
I think that is a really big issue for us about how we properly take account of what the clinical world is going to look like 10 years from now, not 2 years from now. And I think Joe, with Tracy and Chris, we need to push the planners. We need to push the planners to do that horizon scanning work quite rigorously, really. Otherwise, it will almost inevitably be kind of short, relatively short-term stuff, or the kind of fad of the moment. The interesting thing that somebody at NHSI read about somewhere or saw once, which is not really quite the same as a proper systematic kind of horizon scanning sort of process. Amanda.
Yes, thank you, Chair. Joe, I just wanted to acknowledge that what an exciting time this is to take over the leadership of an organisation with this programme of work. And I think the conversation has already reflected how complex it is to get it right. Future proofing anything is really, really difficult. But I think that the beginning of the launch of the consultation and the conversations, we will get it as right. But what I wanted to understand, Joe, is if there are any emerging thoughts from our partners, particularly the Sussex Collaborative, on their expectations?
Not at this stage. I think that because we haven't got the designs to share with them, that they are very much part of the programme board. I think what we will need to make sure is that the ICS planning, and as we've talked about offline, is that the plans will need to evolve in line with the ICS plans. But at the moment, whilst we've got a sort of view of outcomes for places and for the ICS, which we'll need to take into account, I don't think we've had specifics at the moment that we need to pull forwards, but it's a good question, and we'll make sure we pull those that feedback in.
And the other side of that question is obviously being an integrated community trust, the work with the community and the local authorities will be equally as important. But thank you.
Karen?
Yes, just following up on the conversation about designing for the future and using the health planners and NHSE and everything. Where we're looking to become the best in or outstanding in different departments, like best in frailty and things like that, can we also expand that horizon scanning to the international stage? Because I'm concerned that we tend to be very UK centric.
Yeah.
And if we really want to look out to the future, it's about gathering what may be radical ideas. We may not include them all as quite so radical, but I think there are some countries in particular that do very well with frailty that we would be helpful to look at.
Yeah, no, that's a really valid point. So I'll pick all of those up, and I'll speak to Tracy a little bit later.
And just to add to that, not to labour the point, I agree with that. I just agree with the point entirely about international best practice, and we have a really peculiar habit of assuming that means looking to the United States, whereas I think probably India is the most innovative place in terms of hospital organisation method and systems around, and has been for the last decade. So if we were really looking to something that kind of challenged some of the more traditional ways of organising things, India is much more of an interesting place to take a look at, I think. Anyway, that's for another day. So good. Thanks, Joe. So let's move on to the integrated performance report and start with quality and safety. Is that you? Are you kicking off, Vicky?
Thank you, Chair. I will, and I'm sure Dr. Walker will join in and discuss mortality. So just a couple of things I wanted to pick out, and we had some very helpful discussion, I think, at the Quality Committee that Jackie's alluded to. We did discuss the Never event, which was declared in August, and that was relating to the use of high flow air instead of oxygen. The patient is absolutely fine, and there's already been a significant amount of work undertaken, and I've asked for an update report to go to the next Quality and Safety Committee about progress. In terms of pressure ulcers, nothing specific of concern to report. A theme that we are seeing is in relation to damage occurring in patients' own homes, and in the main, patients who have capacity declining or refusing advice or treatment. So working with our community teams and ensuring our risk assessments and record keeping is reflecting that. And we have a process that we refer to as planning care together if patients choose to take more risk. I am working with some colleagues about reporting on pressure ulcers, and we're trying to look at that in a different way, and I look forward to discussing that with Jackie and Karen and others at the Quality Committee about how we can better capture and reflect some of the changes in pressure damage. They can deteriorate and they can improve, so not quite as easy as reporting on falls, for example. In terms of non-COVID infection control, one MRSA bloodstream infection in August, we haven't been able to determine the source of that, and there's no evidence of any contributory lapses, although we did pick up on some points. There was a slight delay in screening, so some further education and audit underway as a result of that. In terms of workforce, in the last few months, we have still seen some significant challenges. We have, until quite recently, needed to have quite considerable amounts of additional capacity open. And we still have the ongoing challenges. As Joe alluded to, our new way of working in terms of infection control and our red and green areas, or low, medium and high risk areas, So that is a challenge, but we are working together on that and working closely with Imran and all of the operational teams on a daily basis, and lots of work underway looking at the next 6 months and beyond. And finally, just in terms of COVID, not much more to add really, as Joe says, still locally a very low prevalence. And we are working very closely with our Public Health England colleagues and the rest of the system. And really our key areas of focus is about local prevalence and knowing our local data, and also the doubling effect. And just again, I wanted to thank our volunteers who are still supporting in a number of areas our meet and greet service, but hopefully anyone who's come through any of our main sites will now see our automated mask and sanitizer stations, which have been an important addition. I will ask David if he's happy just to talk to mortality, and then David and I are very happy as always to take any questions.
Great, thanks, Vicky.
Thanks, Vicky. Chair, would it be useful just to show you the latest cases of COVID in East Sussex? I have the up-to-date graph if the board would be interested.
Yeah, that would be very helpful.
I'll attempt to share that. And so while it takes a while for these things to work, I'm afraid. So in August, COVID admissions and deaths were very low, and likewise in September there was a bit of a blip of local cases in East Sussex early in September, and we were worried that that was indicative of it coming back, but in fact it then died away again, sustained end of September and early October. Can you see that now? Is that appeared? Yeah.
Yeah.
Somebody say yes.
Yes.
So
David. Yep.
yeah. So you can't believe the low figure for the 3rd of October. That's too early. That the numbers there will catch up. But you can see we had this blip that I was concerned about in September. I was worried this was on the way up, but then it all died away, and now we have a second rise. When you compare these numbers locally, Kent is fairly similar. West Sussex has considerably more, over I think 230 cases in the last week, and Brighton and Hove are roughly similar to us. I've seen the figures from the north of England, and they're now roughly at about 25% of ICU and hospital admissions, as compared with where they were back at the peak of the crisis, of the first wave. Vicky hasn't mentioned testing, but testing is still an issue for us in terms of admissions. We, as you know, we have a machine called the Kefid machine, which actually could do several hundred a day, but we're not allowed to do several hundred a day because there is insufficient materials to do the tests, and so we're restricted to 40 cases a day. We have a new fancy machine that has arrived called the Perkins-Elmer machine, which is being sort of put in place at the moment, and then we'll need testing over the next couple of weeks before we can start using it. But once that is available, we will be able to increase our numbers to several hundred tests a day, which will allow us to do tests on patients who are coming into hospital in-house rather than sending them to Southampton, which will make life a lot easier for us. There's also a Menarini machine, which we potentially can do very rapid testing on new patients coming in. You can get a result within 20 to 30 minutes, but you can only do one at a time. And we have 3 of those machines, which might be able to do about 70 a day, which would certainly help us with the positioning of patients. Turning now to mortality, the SHMI is stable at 97. It did go down slightly lower than that sort of early last year, but rather annoyingly that was at the time when we weren't able to see the figures because there'd been the error with NHS Digital, and so by the time we knew that it was a very impressive 94, it had already gone back up to 97, which is disappointing. Why it has gone back up is not entirely clear. There does seem to have been a slight increase in the crude mortality rates, even ignoring COVID, from 1.44 to 1.59, and there's no obvious reason for that. I do have some suspicion later on about why mortality has risen in that whilst we were focusing on COVID, some of the other patients I think got less attention, and also a lot of patients stayed at home for longer than they should have done and came in rather sicker than they might otherwise have done. And so I think that has increased non-COVID mortality. All of the shimmies and rammies, I should say, exclude COVID because those indicators were not designed for pandemic, which is a bit of a shame in a way, because we did so well during the COVID wave 1 that in fact we would have been right at the top of the tree in terms of mortality if shimmy and rammy had included COVID deaths. I've also included on the page the liver disease, alcohol-related liver disease deaths. We were a major outlier for that a couple of years ago in 2018, but there has been work from the gastroenterologists and we are now better than peers. And so I just put that in to demonstrate. And I think that's all I need to say. Thank you.
Great, thank you, David. Jackie.
Thank you. I understand that we're restricted on testing, but I'm not clear on what is the impact of COVID or contact tracing on our staff and availability of staff. You've made reference to it in terms of fill rates, but I just wondered, how are we able to see the number of our staff who are impacted by COVID and what that does to our capacity?
Well, I'm sure, I think it appears in Monica's workforce report in terms of numbers, but there has been restriction of Pillar 2 testing locally because a lot of that capacity has been moved up north where the second wave seems to have hit much harder, much sooner. And so it has been an issue with staff getting tested themselves if they've had symptoms, or indeed if a member of their family has had symptoms. We are trying to help out with that testing and test those people, or at least do the swabs in-house, but at the moment they do have to go to Southampton, and there is something like a 42 to 46 hour delay in turnaround time. But once we have the Perkins-Elmer machine up and running, we will actually be able to do that testing in-house, which will make life easier in terms of getting staff back to work. And obviously it's going to be much more of a problem now that autumn has hit, as people tend to have more coughs and colds and temperatures during this period of the year. And so differentiating the usual cold from COVID is going to be important. Otherwise we will have large numbers of people off. Monica, I don't know whether you want to comment on numbers of staff that are off.
I was just going to say, we do collect those figures, Jackie, on a daily basis. The numbers of staff that are actually off sick, those that are off with COVID related, or those indeed that are having to shield. The numbers are actually quite low at the moment, particularly related to COVID or having to shield. But we will continue to collect that, and we can share that if you find that helpful. But that is done on a daily basis.
Yeah, I think my point really is, the absolute numbers, but also where it has an impact on our ability to see patients. That's, wherever that might be, that would be useful, I think, to understand its impact.
Yes, I think it does have an impact, both like David says, in terms of staff getting tested, and also staff that have to be off because of other family members or childcare responsibilities and things. Yes.
Okay.
Vicky, did you want to come in on this point?
Thanks, Chair. So, Jackie, the answer is yes. Some of our staff have managed to access the national test and trace system, and particularly for an index case in the household, usually, but not always, children who are now back at school. So we have seen some of our staff affected by that. And actually, we have been offering testing, as David says, to some of our staff. We actually already have now on both the Conquest and the Eastbourne sites additional pods, and a small group of us have been working on staff testing, so that when we have significant additional in-house testing capacity, then actually that will be for staff as well as our patients. And we're also looking at the possibility of not just offering that to our own staff, but also supporting the system, the local authority, possibly schools and care homes. I'm delighted that we also now have a service level agreement in place for mask fit testing with local authority colleagues. So we're hoping that over the next couple of months that the national testing situation will improve. But in the meantime, we felt it would be prudent that we significantly increase our capacity. So very happy to keep the quality committee approaches.
Is that affecting? Have we got incidents where we are unable to provide the service because of staff availability, or are we okay?
We have had, there's certainly staff I'm aware of, that hasn't resulted in a significant disruption to any particular ward or service, but if of course there's an impact, and that's why we've had the process in place, that we have been able to get those members of staff in and test their index member in the family so that they can get a negative result, hopefully, and they can get back to work. So it's caused some issues, but we haven't seen significant disruption so far.
Okay, thank you.
Thanks, Vicky. I've got Karen, then Miranda, then Nikki.
Thanks, Chair. David, just to go back to the Perkin-Elmer machine, 2 questions there. When will it actually be operational? Like, when will the validation and things be complete? Because obviously getting it into the hospital is one thing, but there's still a process. And then can you confirm that there are no risks of reagent or materials shortages with the Perkin-Elmer machine? Do we have that reassurance? And when do we expect the reagent situation to improve for the initial testing facility, the one that we can only do 40 a day? Because actually,
okay, so yeah, so the answer to the question, so we think that the Perkin-Elmer will be another 2 weeks before it comes online. They had to do some works within the room it was going into. There are some staff training issues, and there is the validation process, as you say. So realistically, it's another couple of weeks before it's functioning. We are not aware of any difficulties with the Perkins-Elmer, and so we should be able to do, if we do 2 runs a day, we might be able to do 600 plus tests per day on that machine. However, I would say that when we purchased the Kefid machine, which is the initial one, which we're now only doing 40 a day on, we were told that there were no issues about reagent there either. So you know, I personally think that the company there are reprehensible, because they were selling these machines all over the place, and then they went, oh dear, we haven't got enough reagent for all the machines we sold, we're going to have to cut you down, and they cut us down to 60 odd tests, and then cut us down again to 40 odd tests, and that was because they were gleefully selling their machines across the world. I don't think that's going to happen with the Perkins-Elmer. I think that would be scandalous at this stage of things, and we've got no indication that it would be. In terms of the Kefid original machine, there is no prospect of increasing our numbers from 40, but we will continue using it for 40 because it's a very high quality machine, and the results are very reliable. So we will factor that in, and we will continue to use it. But sadly, I don't think that situation will alleviate at any stage soon.
Sorry, Miranda.
My question was about MRSA. I wondered what it was about the MRSA infections, rates of infections, that was giving you cause for concern, because I noticed that you singled it out as a special cause variation, whereas the C. diff track record looks also quite bumpy, and you don't. So is there anything in particular about that, and could you say a bit more about it?
Sure. So I'm not at all concerned, actually, but case, given, yeah, it is one case. So I did single it out because actually they happen very infrequently, which is a good thing these days. So I thought it was important to talk about that one particular case. In relation to C. diff, we had a very slight increase above what we would usually see. But we are still well under our limits, so I don't have concerns about that at the moment. And all of our bloodstream infections, albeit they're tiny in numbers, and our C. diffs are subject to either a full root cause analysis or a post-infection review, and we take all of those through our infection control committee, which reports into our quality and safety committee. So no concerns at all, Miranda. It was just because, thankfully, the MRSA bloodstreams are very infrequent.
Yes, it's just that on the summary sheet, you've got special cause variation for the MRSA, but not for the C. diff. So I just wondered.
We're allowed C. diff cases, but we're not really allowed any MRSA cases. I think that's the difference.
Indeed, and the numbers are so tiny, one will cause a concern.
Absolutely. Thanks, Miranda. Nikki.
Thank you, Chair. Just two questions. The first is in relation to the serious incidents that are listed on your page 7, I think it is, slide 7. There were 3 that mentioned delays. I just wondered whether any of those were COVID related. And then the second piece, again, in the serious instance, there were 3 women that developed abdominal infections post-caesarean section. And I think I also picked up in the health and safety report that one of the highest areas with incidents was one of the maternity wards. And whilst that report acknowledged that there weren't any common themes, I just wondered whether we were looking into the commonality of location, which could obviously reflect, for example, the way teams work together, etc., and whether we're focusing on that at all. Thank you.
Sure. So David may, I'm sure, want to comment as well. And actually, I'll be bringing a full report on incidents and serious incidents to part 2 of the board as well. I think in terms of are we starting to see incidents or concerns because of the COVID, I think the answer is sadly yes, we are, albeit quite small in numbers. But David may want to say more about harm reviews, and certainly across the system and around the country, both the chief nurses and the chief medical officers are focusing on harm reviews to understand exactly that and what the impact has been for patients who have not been able to access services in the normal way. I don't know, David, is there anything else that you want to say about harm reviews or incidents?
So in the harm reviews, Tara Argent has produced an excellent document for looking at harm reviews, which we're now implementing, and we will have a report on that in due course as the data comes to light. I'm only aware of one definite significant delayed care leading to harm, and that's the one at the bottom of the list of serious incidents there. With regards to the women's and children's situation, Nikki, I don't think we're concerned about there being a problem in women's and children's, but the issue with those 3 ladies was that during the COVID crisis, the usual surgery cell, I think it's called, was unavailable, and we had to get supplies from a different company, and it just hasn't worked as well, and it has led to significant problems, and so we've withdrawn it from all areas of the trust and have reported the issue with it to the MDA because we are concerned that there's a problem with the actual product, and we've now been able to go back to the original product that was in place, and so we have no further concerns. But I think it was an issue with with delivery of the usual product that, during COVID that led to that issue.
Vicky.
Thanks, Chair. Nikki, as well, it's very important, I guess, to clarify that a little bit. So there is no suggestion or concern that the product was unsafe, if you like, but the product was probably less helpful in certain situations. So it's a hemostat that stops bleeding. So there's certainly no suggestion that it was in any way damaged or unsafe, but it was about a different product that was less helpful. It's probably important to say that.
Okay, so it's efficacy of product rather than
yes.
There wasn't the product. It wasn't defective.
Yes.
The product just was not as effective in the situation to which they were used to using it, and so it led to issues.
Thank you for that clarification.
Great. Okay, thank you, Vicky and David. Imran, shall we move on to access, delivery and activity?
Thank you, Chair. So if I start off with planned care positions. So currently, in relation to cancer, Our July position for 62-day cancer standard is at 76%. The August position is better at 79.7%. Now, during that time, it's worth noting that our over 104 days for cancer weights have continued to reduce, and they're kind of stable at about 38 patients. And that's because we are going through clinical harm review, which David has very eloquently described. So that's a process that's very clinically led. And so we're going through harm review for all our long waits, and we're also dating patients as appropriate. As a result of that, the September expected position around 62 days currently is at 65%. And that's absolutely the right thing, because we are now beginning to date a lot of our long waiters who've gone through the clinical harm review and have their pathway validated. So it's just to expect that position going forward, in the sense that that is our live performance position. So the more patients we date that have exceeded 62 days, particularly over 104 days, which is the right thing to do by patients and from a safety perspective, that percentage will be lower until we get to a point of clearance of 104 days and reduction of 62 days. So based on that, the over 62-day position currently on our patient tracking list, which is the PTL, is at 130, and that used to be consistently 164 as we built up our backlog, and is now going in the right direction. And that again substantiates the position I just described in relation to September expected to be low at 65%. So we are dating more of the high weights. This week again, for the month, we've had a Cancer Week focus where we are validating every pathway and making sure that harm reviews are checked, reinforced as we go through via our clinical teams. There's increased focus around pathways and safety and ensuring appropriate dating of patients, which is all clinically driven by clinical colleagues. And there's also weekly cancer patient tracking list meetings with our specialties and divisional level, including at tumor site level as well. And that basically then results in actions being taken on a daily basis. So in terms of assurance and governance, there is that rigor in place. And also, I think worth noting that our elective care board is now fortnightly, because every other week we have an RTT meeting as well that goes through the details in the same kind of rigor and depth as I've just described for cancer. Going on to the RTT, referral to treatment position, the August situation was 71.4%. The September expected position is higher at 75%. Now, this is converse to the cancer position, where cancer looks at treatment percentage. This is looking at clearance percentage. So the higher the percentage, the better it is, because we are clearing our long waits. So just worth noting, I know some of you will be aware of this, but just noting that trend. So September position is at 75%, and that's predicated with our stabilizing of the over 52-week weights. Currently, we have 235 patients who are over 52-week weight. And in fact, today we had a system meeting this morning that both Tara and I joined in from our perspective in contributing our trigger and tipping point across Sussex in relation to elective care escalation process. And the comment was made that across Sussex, East Sussex was definitely in an improving position. So I think it's worth noting that as well. Obviously, no time for complacency, and we'll continue having that rigor and grip, but it's worth noting that we are going in the right direction currently. The risks, however, remain, and we've already covered that as part of the BAF. Of the 235 over 52 weeks, 50% of patients have dates, which again reinforces that we are going in the right direction. For follow-up position currently, at any point in time, there's 12% of our follow-up cohort of patients that have booked date. And predominantly the reason being that as we're going through our follow-up situation and the PTL, of which there's about 21,894 patients to be precise as of yesterday evening on the follow-up patient tracking list. 12% of that cohort is dated, and the reason why we've got 12% is because we're constantly checking on a 2 to 3 week basis as we're validating the pathways, clinical harm reviews, negotiating dates with patients, and then getting them booked in appropriately. So that position is stabilizing as a minimum and will continue to grow as we go through. And it's worth noting that cumulatively, I'll cover the remaining elements around the restoration and recovery in the recovery section, is that 40% of our outpatients remain non-face-to-face. So that's a good position that we're holding currently, and we'll need to build on that going forward. Diagnostics, which is a key component, we are currently at 28.1%. Now, the standard, I'm sure you're aware, is 1% over 6 weeks, but currently we are at 28.1%. Having said that, radiology activity numbers have increased to about over 10% in terms of trend. So that's a good position. When we look at our CT, we look at our MRI and other modalities, it's going in the right direction. And so we're consistently pursuing that traction and activity numbers. I've already mentioned clinical harm reviews. We've got a clinical advisory group who will be signing off the current final version review process. The place and system-based triggers I've already covered briefly earlier, that we're meeting up as part of the Sussex integrated care system to work out mutual support arrangements across the patch, looking at independent sector arrangements as well. And if we do get to a very difficult winter position, potentially with COVID against it, the impact on elective care we've already kind of touched on previously. So what happens then as a system, and what could we do better collectively? So those conversations are happening. And in fact, if anything, the intensity is increasing as we go through the next 4 weeks. If I then cover emergency care, and then I'll be opening up to questions if that's all right. From emergency care perspective, the August position is 89.6%. That was mainly driven by Eastbourne, where we had a middle grade vacancy, and whilst we've recruited to the middle grade vacancies, they've not started as yet. So we've tried to backfill, and August in particular, being the holiday month, was difficult to get backfill for, particularly with the local market as it was. And the other thing as well, which I did mention when we all met up as part of the NED meeting on the 29th of September, was that we did have the red and green bed situation where there weren't very many COVID patients, and we had red areas that we had to look at converting to green in a managed transitional way, where Vicky and I were working very closely with David and the divisional colleagues, and we managed to do that certainly for September. The September position is 91.2% as things stand currently, and that's really encouraging. And in October, we've been in position where nationally we've been about 5th or 6th in terms of our emergency care performance to about 21 to 21st across nationally. So I think that's a good position, and just to be able to reinforce that, I think the teams have worked really hard in managing that situation. Jackie, I think, mentioned around the discharge element around patient safety. So we are focusing on Rapid Improvement Week, which we had in September, on the 14th of September, and we're having another one next week, particularly focusing around the discharge component as a system. And only today, I had confirmation with our system colleagues around looking at Rapid Improvement Week, looking at our medically ready for discharge patients, and ensuring that we had another focus of improved discharges across the hospital, particularly as we gear up towards ensuring that our elective care capacity is freed up, particularly at Eastbourne site. So that's work in progress, and I'll obviously update the next board meeting. So in summary then, we've got High Drive for Patient Flow Programme, of which there are 5 work streams, as I mentioned previously. We are focusing on internal improvement, particularly at ward level, which links up to quality discharge practices internally, and working with our clinical colleagues around that, but also as a system looking at the discharge hub to actual discharge of patients. Some of those components I'll cover in the winter plan update as well. And Joe has already mentioned NHS 111 work. And one more thing to mention is our work with CCAM, the ambulance services. where on the 12th of October, we've got a rapid improvement week where we test and learn the standard operating procedure we've put in place. And early indications are that there is already improvement around our wait times and ambulance handover times in the last couple of weeks with the changes in the standard operating procedures. So watch this space, and I'll definitely update you all later. Should I open up to questions now before I go on to recovery?
Yeah, let's take some questions now. Jackie?
Hi, Dev. I've got a concern, and I don't know if it's real or not, that if we're doing virtual outpatients, and I understand follow-up is particularly valid, but if we're doing new appointments as virtual, and then we're sending someone for diagnostics where there is a delay, are we in danger of elongating that referral to diagnosis for people, rather than managing to get that pretty almost one stop before for a lot of places? So I'm just looking for assurance on the time to first referral to diagnostics. Is that elongating for people? And my second point, just on discharges, care homes need people to return to them before lunch. We need to get better at morning discharges. But the question's on the first point.
Okay, thank you, Jackie. And I'll let David comment on this further. But the first thing to note is the non-face-to-face is clinically driven decision. So it's always reviewed from a clinical perspective and is part of the pathway validation work by our clinical colleagues. The second thing is that the non-face-to-face is predominantly around the follow-up, because the national position is 25% of first appointments would be appropriate and 60% of follow-ups for non-face-to-face. So we're kind of loosely following that as an aggregate position. So David, I don't know if you want to comment on this, but certainly from a clinical pathway perspective, that is being monitored. And as part of the RTT weekly and the elective care board as well, it's looking at that time between first appointment and diagnostics and chasing down patients that are elongated, because we're very mindful of the risks, Jackie, that you've outlined. And on the second point, very quickly to cover off, that's exactly why we have the rapid improvement week, and we're driving earlier discharges, looking at earlier arrangements, and in fact, getting to know the discharges for tomorrow, today, and getting them prepared by the evening, so they're ready to go first thing.
So I think everything that Imran said is true, but that notwithstanding, I do share your anxiety about this, Jackie, and I think certainly during the peak period of the first wave, when we were doing all of our outpatients by telephone or video link, there will undoubtedly have been some people, and at that time we weren't doing some of the diagnostics that are required. Certainly some people will have been delayed, and we have to work through all of those patients now and see if that has caused us any problems. There are, of course, also some high-risk medical staff who are very anxious about returning to face-to-face, and I think we have to be quite clever within teams to look at who should be seeing people face to face. For example, in cardiology, I'm quite happy to see people face to face. I've got lots of antibodies, and I think probably it's safer for me than it is for some of my non-Caucasian colleagues to be seeing patients face to face. So I think we have to be quite clever in terms of teams and who sees what. And the other issue of telephone consultations is that when you can't examine a patient, I think it does probably increase the number of patients referred for diagnostics. So in cardiology, if you haven't listened to the heart, you're more likely to order an echo, and so I think we have to be cognizant of that as well, because we don't want to be converting one waiting list into another waiting list in terms of DMO1. So I think that we've done really well, and I think that it's an ever improving picture, but I think we have to be quite clever about the way we use these telephone consultations, choose the right people for them. I think there needs to be a bit more analysis of when letters come in as to whether or not patients are suitable for telephone or whether they need to be face to face, and then I think there needs to be quite sensible allocation of patients within teams for people who are safer seeing the public and keeping those that are not on telephone consults. So I think there is more work to be done, but we have done a lot.
Thank you.
Thanks. Joe, were you trying to come in on that point?
Yes, so it was just very briefly. So as part of our outpatient transformation programme, we have been working with PA Consulting It's an 8-week rapid, we keep saying rapid improvement, but that's because we like to do things reasonably quickly. But the idea is that we are working with 8 specialties to design the pathways so that we're really clear which patients and on what pathways we would design to have a follow-up or a first as a non-face-to-face. So rather than it sort of being that ad hoc decision, that it's absolutely clinically driven. And what Imran and David said are right, but we want to make sure that it's something we've designed into pathways, and also that we've got patient-initiated follow-ups as part of that, and putting the patients at the heart of sort of driving and being part of their own decision-making. So we can share that in due course as we're in a position to do so. Thanks,
Joe. And Richard, were you on the same point?
I was, Steve. Yes, it was just to come back to Jackie's comment about patients into care homes. One of the issues that we picked up on the system-wide call this week was that we know protocols are not the same across the whole of Sussex. One of the issues around that is it's been flagged to us. We're not seeing it in East Sussex yet, but the specific concern was that care homes in West Sussex are refusing to take patients without negative tests. Obviously, there was always the issue of patients still shedding, potentially presenting as positive even when they're not. So that, from our perspective, the challenge there is around medically ready for discharge patients who we know can go elsewhere, but we can't actually move out. So at the moment, that isn't an issue for us, given the volumes and given what we're hearing from the care homes in East Sussex. But we are aware that potentially, were the West Sussex behaviour to move across, that could potentially store up a bit of a challenge for winter.
Thanks, Richard. Amanda, waiting patiently to ask your question.
Well, luckily, most of my question has been answered. It was actually about the rapid improvement events that are going on and what the learning is, because my experience of rapid improvement events is they're great for the week, but then practices slip back into it. And so I get it, and Joe's explanation of the pathways that are being targeted. But I think it's really important that we understand what the objective of the Rapid Improvement Week is, what the learning is, and how that's built into our transformation programme. Because with no, not to be too pointed about it, you know, we know that discharges before midday are absolutely crucial for our frail elderly population, and we've known that for a long time. So I suppose, are we clear about what the identifications of the barriers are as a board, and actually what we're doing to remove those barriers in preparation and as part of our winter plan? And it's not for answering now, but I think Joe's explanation of the work that's going on with PA Consulting, it would be really good to see that back at board and what our mitigations are.
So let's take that as a challenge and a rhetorical point for colleagues who are working through the not so much rapid but making reasonably prompt activity kind of process. Okay, thanks, Amanda. So Imran, so the recovery and restoration papers I thought were very clear. Is there more elaboration needed, or shall we just move to questions?
I think just to note the current latest position as of yesterday evening is that we're doing well around outpatients. So first outpatients are currently, based on our previous activities, at 86%, and follow-up is at 90% of previous activity, and they're both above our agreed stretch levels currently for September as things stand. Day case and elective inpatient is kind of continuing, and that's as expected, and we're cognizant of the need to free up bed capacity, which I've already mentioned. So I think that's the key thing to mention, and the fact that from radiology point of view as well, we are increasing that percentage point despite all the challenges. So the teams are doing really well on that front.
Great. I mean, that's a much more encouraging picture than I feared that we might have been at when we first began to talk about this 6 or 8 weeks ago. But any questions from colleagues? Karen, and then Joe.
So just a question in terms of the elective inpatients. On the current sit rep, you're showing the 4-week average is 63% and the September plan was 75. I'm just wondering whether you've got an update on that 4-week averages now that we're into October, because it just seemed like there was a big jump to get to the September plan.
Yeah, so the ESHT agreed percentage for September was 65% for elective inpatient as part of our submission. Because there's two elements, Karen. One is around the national, the phase 3 expectations, which was 80%. But as part of our sense check locally and part of the Sussex-wide submission, which there was confirmed challenge, the ESHT agreed position was around 65% of achievement that we put forward. And so currently our elective inpatient is at 66%, so it's a percent more than what was agreed. But the challenge still remains. I don't want anyone underestimating the challenge around electives. Nevertheless, is that the next element around 75%, 80%, that is going to be a challenge which we're working through. But currently we are kind of thereabouts in terms of what we submitted. Thanks, Joe.
I just wanted to add there will be a step change. So at Eastbourne, we only have one elective ward at the moment, which essentially was Litlington, which is our day case unit, which is currently having inpatients and day case. Mitcham will be back available for electives. And allows us to bring our gynae and our orthopaedics back to Eastbourne from next week. As you'll be aware, orthopaedics needs to have a completely isolated area from anything else due to infection rates. So this will allow the side rooms to come back for orthopaedics. So that will allow a step change to support that at Eastbourne.
Is that okay, Karen? Does that cover everything? Great. Thanks, Imran. Let's move on to workforce. Monica, for the last time.
Thank you very much, Steve. Most of the workforce metrics remain fairly stable since the last report, but I just pick out some of the key highlights which may be helpful. Firstly, in terms of the vacancy rate, that's now at 9.5%. It's important to note that that compares very favourably with vacancy rates in other NHS trusts and indeed across our local system. And it's also worthy of note that it was 10% this time last year, so we have made some good progress. In terms of vacancy, the highest rates are amongst medical and dental staff, where we do still find it hard to recruit in some areas, and the rate there is 17.8%. But having said that, since July we've recruited to 34 medical and dental vacancies, so that's really good. We've also had a lot of success in recruitment to nursing midwifery post and our AHP post, so again a positive. Some of the COVID restrictions has made that it's been more difficult to get some of our staff that we usually rely on coming from abroad. But having said that, we've got another 50 overseas nurses joining us before the end of November, and there'll be a very important addition to our workforce. So we're very much looking forward to that. In terms of turnover, there's only been a marginal change. And it's now 10.1%, and again that remains very positive. The main reasons that staff leave the organisation are either retirement or due to career advancement, so we need to look at that in terms of really understanding what we can do in terms of our leadership for staff, their training and development, and where we can provide them with opportunities within the trust rather than leaving. In terms of the look at the workforce, 84% of our total workforce spend is on substantive staff. The rest is on agency and temporary workforce. The amount of agency is still fairly high, and that's partly because of the problems we're having in terms of recruitment. But in terms of that balance between our own temporary workforce and agency staff, we are filling more of the shortfall by our own temporary workforce. So I think that's really positive. Moving on to sickness, there's been little change. 4.1%, it's a little change since the last month. The highest area for sickness, as it always is estates and facility staff, and that goes with the nature of the work for those staff. We touched on the reasons for sickness in an earlier conversation, and that remains related to MSK related sickness and also stress and anxiety. And as we said earlier, we're doing an awful lot to support staff, particularly at this really difficult time. So there's a lot going on in terms of psychological well-being, a post-traumatic stress disorder, burnout, working with teams, etc. And I think that's really important. And we've had some really encouraging feedback from staff around that. Also, in terms of caring for our staff, we are making sure that all staff have a risk assessment to see if they are safe to work. There's 3 categories that we have to monitor against a measure and this look at the board. So for all staff, we've got 96% of staff who have had risk assessments. For those at risk, it's 98%, and for our BAME staff, it's 96.4%. And there's been an awful lot of work in that area. Job planning, very good progress indeed, and we've gone over the 91%, so that's excellent. Miranda mentioned earlier that the staff survey is now live within the trust, and that's the national staff survey. And we also talked earlier about the people plan. So I'd be very happy to answer any questions.
Thanks, Monica. Jackie first, then Nikki, then Miranda.
Thanks, Monica. I've got 4 points. One's a worry, one's a question, and one's two possible optimistics. I'm worried about resilience, and you've talked a lot about what we're doing for staff, but particularly starting at our sort of middle management. These are the people that are under the pressure from Restore and Recover and COVID and everything else. We're only at the start of winter. I'm just worried about resilience of our leaders from sort of 7 upwards. I'm concerned why is appraisal rates falling, which is disappointing. And then 2 possible avenues for optimism is now's a very good time to recruit, and it might be that in science and technology type jobs there is a massive opportunity here as people are becoming available in the job market. So those are my 4 issues.
Thank you. If I could just touch upon them, I think you're absolutely right in terms of resilience, and that is a worry. And that is why we continue to try and do more, both on an individual basis for members of staff and on teams. I think your point about kind of middle managers is really important, and that may be well worth taking back to see if there's anything in addition we can do, particularly for that group of staff who are under a lot of pressure in terms of leading and supporting others and having pressure as well in terms of having to achieve. So we'll definitely do that. In terms of appraisal, I do agree with you that the fall is of concern. When I speak to operational colleagues, they say it's really because of the pressures they're under, and whilst they are spending time talking to staff, supporting staff, etc., in terms of risk assessments, they're not always having time to do the formal appraisals. But that's something again that I will take away and have another look at. And I think your 3rd point in terms of recruitment is very valid, and it's not only in terms of scientific staff, and it's other groups of staff, and in some categories we are actually getting many applications for jobs, and very high quality applications. So in lots of those areas that is indeed very positive. I think, as I said earlier, it's probably medical and dental staff we're still struggling the most with. But thank you for those questions, and I will take back and follow up the residual points.
Thank you.
And on that last point, David, was that something you were trying to come in on?
It was actually to come in on the appraisal situation, Chair. So during the COVID pandemic, the GMC asked us to stop doing appraisals on medical staff, and they were all deferred. So, but we've restarted in October, and so I don't know how much of that dip in appraisals is due to medical staff, but that will start to come back up. Obviously, all medical staff are expected to have an annual appraisal, but we're playing catch up now over the next few months.
Damien, was yours a connected point to that question or different?
Sorry, Steve, not really.
If it was different, then I'll ask you to wait in the queue.
Okay, fine.
So, Nikki.
Thank you, Steve. So mine sounds like a slightly pedantic point, which is, so I'm looking at the workforce churn page, and there's a comment about the figures being distorted for junior doctors rotation. I guess my request or challenge would be, so can we remove that from the numbers so that we can see clean numbers and understand whether we should be worried? And the reason I'm thinking about that is then I look at the annual turnover rate, and whilst, because of the way we're now presenting our data, the last 5 months are blue dots, there is a slight upward trend. And I don't know whether that is something I should worry about because the last month has continued that upward trend, or actually if I take out my junior doctors, whether that has started to go back down again.
We can take out the junior doctors, and we'll do that. However, the upward trend is very slightly still there without that turnover of junior doctors. Thank you. And it's a similar point, but in workforce sickness, can we extract COVID? Because to some extent, that's something that's sort of without our gift of control, although we'd probably want to be tracking it separately. Again, so, you know, looking at the annual sickness, it's hard to know whether I should be worried about that top left-hand graph or not, because I'm assuming all that bright orange is distortion due to COVID, but I don't know. It is indeed, and when we have a more dive into these figures at the People and OD committee, we do actually separate that out. So I can give you the assurance that that is actually looked at the People and OD committee to kind of break that down. Thank you, Monica.
Thanks, Nikki. Miranda.
I have the same question as Nikki about sickness, so that's nothing more, thanks.
Okay. Vicky I think Vicky's next.
Thanks, Chair. It was just coming back to Jackie's question about resilience and the workforce, and just to add to Monica's comments, Joe's been leading the way. Actually, we've had a lot of discussions, all of the divisional IPRMs, and about people's psychological and emotional well-being and how important that is. It certainly isn't just about nursing, but I have still weekly virtual huddles with all of the matrons, and I have weekly senior huddles with the divisional ADNs, and you know, I'm signing my very small team up to a Teams group session, and we're really trying hard to encourage people to access help. Not everyone is keen on doing that, and we're very aware of that, and so I think it's absolutely you know, on everyone's mind, but I think we're doing a pretty good job as a senior team about encouraging people and trying to role model that behaviour to encourage people to ask for help.
Great. Thanks, Vicky. Amanda.
Chair, this is a slightly bizarre question, but just taking the last two conversations indeed about restoration and recovery and the resilience of our staff, and reading the press and hearing the news, there is no doubt we have a second wave on our way. We've seen the stats from David this morning, and that feels, and we've got this really hard task of managing patients who need care that are not COVID related. And I just wondered, as a board, what the indicators that we should be looking at, because we are now asking our staff, we put in resilience packages and support and wellbeing packages for the COVID related stress, but actually we now have the stress of trying to get back to normal. And I just wondered, I applaud the work that's been done. However, we are absolutely walking into a very, very difficult place for our staff in terms of managing winter, COVID and restoration. And I don't have an answer, but I just wondered as a board how we would look at that and make sure that we're making the right decisions in terms of all those three elements, particularly in support of our staff.
Others may want to come in.
Sorry, Monica, to cut across you. I was just going to say that I was looking this morning at the NHS providers recent survey, and I think it's something like 98% NHS provider organisations have exactly that anxiety that you've just described about how we tread the really narrow path of, making sure that we've got staff cared for, that we're bringing services back online for patients, that we're prepared for the normal vagaries of winter and the possibility of a second wave. I don't know that anybody's got the answer. But sorry, Monica, I cut across you, and I think David, you've got something to say on it after Monica.
And I suppose, yes, sorry.
I was going to say something similar, Steve, and we are doing what we can to try and plan for winter in terms of looking at what additional temporary staff we need to take on and even what agency bookings we need to make. So we are trying to do that, but I think you're absolutely right to raise that point.
I suppose it's just not looking at things through rose-tinted glasses, it's taking those rose and actually what's the reality. Yeah.
David, were you wanting to say something on the same point?
Yeah, just to say that for medical staffing, it is going to be much harder because in the first wave, we'd all seen the pictures of what was going on in Italy. We thought that we were going to be in a similar situation, and so lots of things were closed down, lots of people were moved around, and we bolstered the medical teams in the key areas such as the chest wards, the A&E, the ICU, and so on. It has been made very clear to us by the deanery that moving junior doctors around is going to be an absolute last resort this time around. And so we're not going to be allowed to set up surge rotors in the way that we did before unless things get really bad. The BMA have come out with a document basically telling medical staff that they don't have to change the way they work and the pattern they work and move into surge rotors and so on, which I thought was
very unhelpful.
Somewhat unhelpful on their part, because I think if we do have a proper second surge, then that clearly we would have to do so. What I have put in place there is planning, which is a bit more gradated than it was the first time. Last time we had an all or nothing response. We switched off lots of things and moved people around. This time we've got, particularly for ICU and the anaesthetic support, we have a series of triggers where we will move people gradually, depending on the sort of criticon levels we're at, or the surge levels that we're at in intensive care. It's less clear what we can do for the chest wards and A&E because we don't have the extra staff available to move, and obviously moving anaesthetic staff has a knock-on effect on theatres anyway. So it is going to be a much more, I think I said, nuanced approach than it was first time around, and we have to have a series of steps and not an all or nothing response. It doesn't help about resilience though, and that is a concern.
Okay, thanks, David. Thanks, Amanda. Damien, sorry you had to wait so long.
No problems. So I think firstly to say congratulations to Monica, because I think we can all see significant improvements in the recruitment and retention. And I recognise some of the points that have just been made about the pressure on staff of working through COVID, and frankly the risks of going through of dealing with winter as we're heading towards winter. I just want to make one point on a slightly longer term basis. We also need to keep a track of how the establishment is increasing, because that post this year could lead to making us less sustainable.
Yeah, I think that's a very fair point, isn't it? That's a very fair point. Good, thanks, Damien. So on that note, Damien, shall we move to finance?
Sorry, I just went back on mute. Okay, so I'm not going to go heavily into the detail on finance. I think we are ending the slightly parallel process that the months 1 to 6 have led to. We have just submitted our phase 3 restore and recover plan, and by the end of October we will know whether that's agreed. We will then go back to a much more normal type of finance, where we will be held to account for delivering phase 3 restore and recover, and we will also have a reasonably tight envelope to work to. So from the beginning, from October onwards, we will be going back to tracking efficiency and making sure we deliver on the plan, and there will be a risk of not staying break even against the envelope we've been given, both ourselves as an organisation and the ICS as a whole. So I just wanted to, even though it's not that obvious when you're talking about month 5, we're now moving into that world from month 7 onwards. There's just 2 other points I'd like to make about the paper that we've submitted. The first, again, is a slight look forward into September. It's worth highlighting to you that the capital adjustment that we've been waiting for is actually mentioned in the footnotes of this report. We have actually had the 234 million transferred to us and back out, basically repaying the historic debt. So from next month onwards, you're going to see a stronger balance sheet, which is good news to sort of recognise as we go forward. Secondly, I just want to mention the capital plan also looks like a significant improvement. We're now talking about 55 million of investment in year, some of which relates to the BFF programme, and some of which relates to agreements across the ICS, of which 9 million is in our own plans. So that's a significant improvement on previous years. Those actually were the points that I wanted to highlight to you. I mean, there are a number of other points to make in terms of the detail, but frankly, it is much more useful to focus on that from October onwards, because at that point it becomes real. Just to labour my first point again, I would say we have signed up now to a target that has stretch in it. So there is a risk that we will either have to spend money to deliver the Restore and Recover plan, or we will risk losing some of our income under the financial incentive programme. And I think that's true for all trusts. It's not necessarily just a risk for ourselves as East Sussex.
Yeah. Okay. Thanks, Damien. And I know we've covered some of these issues in other fora when we've been together. Any questions for Damien at this point? Parish.
Oh, hi. Thanks, Damien. Basically, one question on the residual claim, which I guess it's going through the system. You know, you actually highlight about 3 million circa, which is still a potential risk for COVID related. Is that just a lag, or is that a genuine risk that they'll come back and say they'll challenge that amount of money?
So I believe month 5, yes, technically it hasn't been signed off yet. Actually, the phase 1 capital has just been agreed after this month has been closed. So I don't think we will see serious risk about month 5 and month 6. I think where we will face significant or additional risk is as we move to a backdated claim process from month 7, and the ICS CCGs will become directly involved of checking the claims that we make. I think there will be an increasing risk from October onwards in terms of what we charge to COVID. I do think we have appeared on benchmarking of having slightly higher than other trusts claims for COVID. So we have already had some questions about what, how exactly we've come to those templates. But I don't think any risk has happened yet. I'm more concerned about the future, month 7 to 12.
Okay, thanks.
Nikki.
My query is about the performance summary as a whole. So if anyone else has any finance questions, it might be best to take them first.
Okay. I'm taking the absence of hands up as license for you to ask your more general question, Nikki.
Thanks. I'm not sure it's a question. So I was just looking at the performance summary page, and I know I get the feeling Miranda possibly has similar kind of concerns is the wrong word, but queries around that page as a whole. And I'm still trying to get my head around how reflective of the organisation is that summary page at present. And I guess my challenge for the executive team is to respond on that point. So taking that as just on face value, I think what that page is telling me that is for safety and infection control, we are on an ongoing basis being quite inconsistent about meeting our targets, but that I probably don't have too much to worry about mortality and caring, and that for operational performance and organisational health, actually in some areas I should be quite concerned. And so I suppose the question is that a fair reflection of the trust at the moment? And if it isn't, are we looking at the wrong things in the wrong way, or the right things in the wrong way, or something similar?
Vicky?
Thanks, Chairman. So, Nikki, I think that's a really good question, and I'm just looking at the summary page here. I think this comes back to, if you look at, for example, under safety, never events has a target of 0, and pressure also similarly, and indeed MRSA bloodstream infections. So I'm certainly not an expert, but I'm thinking back to our board development session about the SPC charts. I think because the numbers are so tiny, when you have that target of 0, that basically any positive case, I think, will show that there's an inconsistency, if you like. So I think it might be an example of where this kind of reporting, I think, is still helpful, but it will constantly raise a flag that I don't think is a really significant flag, personally.
That's where I'm going with, is this the right way to look at this, and is this actually useful for the board to look at it in this way?
So to my personal view, and I'm sure David and others will have a view as well, I do still think it's very helpful. I think it's about understanding, is the target the right one? So is it right that we have a 0? I think it absolutely is. And then the question around, well, if we have had a case, the learning from that, any contributory lapses and so on. So personally, I think it is still a really helpful way to look at data, but I think it's fair to say it's far more helpful for some things depending on the target and the incidence, but that's just a personal view.
Jo?
So I think actually how Nikki summarised it is exactly how it feels and is at the moment, actually. I think, from a safe perspective, we've got, it's saying no significant change. We've got, good assurance. Infection control is the same. We have discussed why mortality is different at the moment, and we can see from a caring perspective that the numbers aren't there because of the FFT. I think if we take operational performance, and the bit probably that does need to change in there is that whilst we are reporting against our constitutional standards, which is right to do, but actually the ask at the moment is actually about getting activity back to normal. So I think those just need to be added in, because that's the ask rather than RTT. I'm sure that will come. Cancer hasn't gone away. I think the organisational health, I think we've already picked up, actually, we have got a reduction in mandatory training and appraisal rates. So actually, I do think that is about right, and the way you've summarised it. And it's also, but it is useful, and I will take away to talk to Gary to make sure that our written summary just reflects that it can triangulate it back really, really easily. So it's a good challenge back. Thank you.
Thanks, Jo. David?
Just to say, I have two things I don't like about this page. I think the whole IPR has improved enormously, and the SBC charts have made an enormous difference to the quality of data that's presenting. It's so much more statistically helpful. And then on the summary page, we put the previous month's figures. And I think that's just that's so irritating. And I have raised this with them before. You know, it really should be the previous year's average figures per month. It shouldn't be 1 month's figures, because otherwise all you're seeing is that tiny variation, which could be the variation in a system which is in you know, a degree of constancy. But you know, if it's going 0 1 1 0 0 1, you might think, oh my goodness, it was 0 last month. It's now increased to 1. That's terrible, but actually it's meaningless. So I think there are some things we could change. I think we could change the it should be an average for the previous year. And my other quibble is I don't like the symbols. I've spoken to business intelligence about this. I don't like the variation in assurance symbols. They irritate me, but that may be a personal thing. So I will shut up now.
Thanks, David. Damien?
To be honest, I kind of agree with David, but that's a separate issue. So I would say, as the front page of us saying, here's our balanced scorecard, I think it's good on quality and safety and good on workforce. I'm still disappointed that it doesn't have finance in it. Okay,
thank you. Richard?
Thanks, Steve. I think this demonstrates that such an open question from Nikki shows we're shedding light on magic here, because not all of us have discussed it. I think we all have some slightly different takes. I think there are a couple of common themes, though. I would go with David. I think the direction of travel is absolutely right. That sense of the summary page, plot the dots, all of the national the national guidance around general trends. I think that's right, and that does probably feel the right areas, subject to Damien's caveat. I am absolutely with David, though, around the presentation of the hieroglyphics. That might be great for Nefertiti. It doesn't mean much to me as a relative newbie. So I think from that perspective, it would perhaps, while the direction is right, we might want to reconsider. I've seen we have got lots of other examples from other organisations where we could perhaps at least have a look. I'd go with that.
Thanks, Richard. Miranda.
Just to say that Nikki and others have expressed better than I did something that has been bothering me about this report for some time. It kind of started off as a bit of a worry about it being so simplified, and then I just thought to myself, well, you're just being, you know, finding it difficult to embrace change, so get over yourself. But originally it started off as a little bit of a worry about the simplification of it and the reducing of spheres of activity to the hieroglyphics. And then it went on to this, sometimes there being a disconnect between the summary sheet and what is actually going on, and especially true where you're dealing with very small numbers. Indeed, you know, today we've had the discussion about MRSA, but I'm very glad that people are now picking up on the fact that also it's a good idea to look at the overall picture, so that you're not in danger of not being able to see the wood for the trees because you're looking at each individual element. I think that's important with this, and also important with the BAF. So yeah.
Thanks, Miranda. So some food for thought there for future IPR report structure. If there are no other questions, thanks, Damien. So on a performance rating, I'm 45 minutes behind scheduled time. We need to find out what the hieroglyph for rubbish is in terms of my